All right, as everyone is signing in, love to have you all put your names and where you're from in the chat so you can introduce yourselves to everyone. All right. Well, I know we're still working on some audio, but what we'll do is we'll go ahead and get started with the introductions as we're working through some of the kinks. So welcome everyone. Really excited that you are here to join us today. This is our first of 3 Winter is Coming series. Today we're focusing on COVID and flu. And I'm joined with some really wonderful speakers that I'm really excited were able to join us today. My name is Courtney Pladsen. I am the Director of Clinical and Quality Improvement at the National Healthcare for the Homeless Council. So it's been a week. It's been a wild week and a wild month and a crazy year. So I just, just for a moment of levity, want to give you a brief visualization of some of the things that I've been feeling this week. Started off great, Halloween, little bright spot. Got to put my son in a fox costume. We didn't do anything, but he hung out in his costume. So that's always fun. Come Tuesday, feeling a little angsty, lots of anxiety, put on a pineapple costume. Still went to work, got through my day, was doing all right. Come midweek, this is pretty much how I was feeling. Little overwhelmed, the wheels fell off. I ate more Oreos than I would like to admit. And here we are on Friday. So, still here. It has been a lot, and I want to recognize that in the backdrop of a global pandemic, but we're still doing the work. And so just want to take a moment of just recognizing that this has been a really hard time for a lot of folks for lots of different reasons. But we're going to keep on keeping on and doing the work. Today, we're focusing on the first 2 aspects of Winter is Coming, coronavirus and flu season. In our next series, we're going to focus on cold weather and natural disasters next Friday. And then to round us off, we're going to discuss eviction and social upheaval. And I'll give the dates and links to these at the end of the presentation. Just a HRSA disclaimer, this webinar is supported through HRSA, and we do not represent the federal government in this work, but they are supporting us through funding. Also just wanted to give a reminder for those who aren't aware, or those who are, who maybe have put in initially, we have a partnership with the CDC for the COVID dashboard. Right now, there's very little information around testing results for people experiencing homelessness. And we have found that this to be profoundly helpful in giving us a lot of understanding of what infection rates are like in this population. And so for those who are interested, you can get lots of up-to-date information every single day on the dashboard. But what we're asking for our community members to do is when you're doing surveillance studies, when you're doing going to an encampment or to a hotel or ACS site and doing global universal testing, we would love for you to put in that data and share it. It's really simple. We only need a few data points that you can really easily upload. So please go to the website. I'm going to have ask that Brandon put that link in the chat for you all to access. A little bit of housekeeping. We're going to hear from our presenters, and then we're going to have time for Q&A at the end. So feel free to, as questions arise throughout the presentation, we're going to wait for questions to the end. So feel free to put that in the Q&A section specifically, and that way, once it's over, we can ask that of our speakers. Again, please introduce yourself in the chat box. We'd love to hear from you and hear from where you're listening. And then evaluations at the end will be shared. They'll pop up on your screen, or you will get an email. So please let us know how we did today. It always helps to improve and inform our work so we can do better. So please share with us your opinions. All right, for our speakers today, love to introduce Sapna Bamrah, physician from CDC, and Kathleen LaPorte, also from the CDC, health communications specialist. We have Crosland, physician, medical director from Unity Healthcare, and Kevin Flowers, practice administrator at Mercy Care in Atlanta. So really wonderful group, doing really amazing work. So we're going to kick it off with our CDC partners and let them introduce themselves.
Sorry, the struggling to unmute. I swear I have more problems. Thank you all very much for having us today. As Courtney mentioned, my name is Sapna Bamrah Morris. Morris is fine, doesn't really matter. But I have been serving on the response most of the last 8 months, either as a clinical role, as clinical team lead. Did engage with Kevin Flowers actually in a large testing event in Atlanta for persons experiencing homelessness, which was the highlight of my response. We had such an amazing time working with Mercy Care of Atlanta. And then also on the vaccine planning unit, which is now the vaccine task force for CDC. And I was sitting on the flu side of the house to really talk about flu vaccination, and have the chance to work with Kathleen LaPorte, who is one of our communication specialists. And I am passing the baton to Dr. David Siegel, who's also here listening and hopefully will answer some questions. So I just want to thank both of them as well. Next slide, please. So I just want to talk about, and I apologize, I usually start this with an elephant in the room picture. I know that the COVID vaccine is the elephant in the room, and if we had more to share about that today, we would, but at this point, we are still awaiting kind of pharma companies to look at the last of their trial of their phase 3s and talk with FDA and figure out how the distribution is all going to go, initially through the state health departments and to direct healthcare workers, which should also include FQHCs and community health centers. But all of that is being worked out by lots of different people, not on our side of the house. So we do anticipate that as we build this infrastructure and continue to strengthen our immunization infrastructure, that will only help to or aid in ensuring that COVID-19 vaccination can be a successful campaign as well. So that's my attempt to address the elephant in the room. But we do obviously expect SARS-CoV-2 to keep circulating as we, I wrote these slides a month ago, we thought that this was going to be, building, and now we see it. It's very unfortunate. And so one of the things that we need to focus on is, I'm sure a lot of people are thinking, well, why flu vaccine? Is that really that important right now? But we have to remember that so much of this is around stress of the healthcare system. We see more complications and more deaths and more transmission of COVID-19 when our health system is under stress and we don't have the ability to keep people as healthy and and the healthcare system gets overwhelmed. So one of the key things I think is the effect that flu vaccination can have on keeping doctor visits and hospitalizations and even diagnostic testing down. So if we have less people showing up with flu-like symptoms, the better we will be. And so again, our campaign is really focused on trying to look at some of our social determinants of health and really reaching populations that are at higher risk. Adults with underlying illnesses, African, racial and ethnic minorities, and adults who are part of critical infrastructure. Next slide. So just one of the big points I think this year is we've been building our vaccine supply over the last few years. We only have about 45% of adults that actually get their flu vaccine. And so we really have room to grow. And one of the ways is to supply more vaccine. So this year there will be more than 190 doses in the US market. That's the most it's ever been. We know it's going to get harder. It's harder right now to reach everybody. And so in addition to having more, we expect this season, the flu vaccine season, to go longer. And we'll talk about that in a little bit. So again, you all actually are the experts on outreach to high risk individuals. You guys know how to do that better than anybody. And so, our push is to say, please don't stop that effort just because we're at the end of October. In fact, we should just be ramping that up. And then we want to align our flu and COVID-19 messaging whenever possible, particularly to high-risk individuals. Obviously, social distancing, mask wearing only will help us with flu, but vaccination is the next big step. Next slide, please. So I just want to briefly touch on this, and there is, we can share, Kathleen and I can share links to talks that you all can access online for clinicians. But co-infection with influenza A and B viruses and SARS-CoV-2 can occur. We actually initially thought that this wasn't really happening. And so if you would have called the CDC in February, we would have said, well, it's probably unlikely that they're both infecting you at the same time. And then we had some cases that really changed our mind about that. So they can co-occur. It's been documented in case reports and case series. There are obviously overlapping signs and symptoms with either infection alone or together. And the frequency, severity, and risk factors are completely unknown at this point. We only heard about 93 cases in Wuhan, 49% with influenza serologically diagnosed. But so it's just really hard to know. And so I think we have to function like both can happen. So testing is needed to distinguish them. They are otherwise present very similarly. And so we have to consider flu when you're seeing a patient, SARS-CoV-2 or co-infection. And so the key thing here is to remember that one of the key treatments now in COVID-19, particularly if someone is showing more severe or at least moderate symptoms or O2 oxygen deprivation, so they're having low O2 sats, dexamethasone is a really important treatment at this point, but it may prolong your influenza viral replication. So we need to understand that, and it might be worthwhile to be a little bit more aggressive with flu treatment if you're going to use dexamethasone. Next slide, please. So which outpatients should be tested for flu? I think, I'm sorry, did we skip a slide? Okay, that's fine. So, again, I think the issue is if you are, I think the biggest point here is to know your community rates. So there are labs in our academic health centers, in our health departments, our public health lab. When we have these sentinel sites that are doing testing, and when they start to see influenza picking up in the community, that's the most important factor. So whatever those, those canaries in the mine, like in terms of testing, what labs report that information, how you access that information from your health departments, there's no more important year than this year to know when we start to see flu circulating. Certainly the CDC flu websites it's fantastic. They always have a map up there as the season starts. You can track it as it's moving across the country. And we have this tremendously small Southern Hemisphere outbreak this year. So we don't know when it's coming. I think we do know, though, that if we don't vaccinate, that we will set ourselves up. So, so again, who should be tested? Because they present so similarly, COVID-19 and flu. If you're seeing someone with a flu-like illness, I think it's all the more important to do whatever kind of testing is available to you. And if you were to watch the COCA slides, and I think even a couple of slides here, it talks about the different tests. And the truth is, it's about what's available to you and just understanding the limitations of the rapid test if that's what you have. Next slide, please. So again, in an outpatient setting, collecting upper respiratory tract specimens as soon after onset is possible, preferably within 4 days of symptom onset. An NP specimen is what we want for ideally for either illness. If you can't do that, collect combined nasal and throat specimens. If mid-turbinate nasal swab specimens could be collected over throat swabs. They actually showed in COVID-19 they were as good. I think in flu, we have similar data. And then flocked swabs should be used over non-flocked swabs. We can go to the next slide. And in terms of treatments, again, I just wanted to list these here. Again, the COCA call, the clinician outreach call that CDC does, that you can access the recording. Tim Uecke and Angie Campbell go over this a little bit more in detail. But essentially, these are our meds. What you guys are mostly concerned with is Oseltamivir or Tamiflu. Baloxavir is another oral drug that may have important use this year, but again, that's going to be about access to that drug, and the cost may be prohibitive. What I think we should remember is that if you are seeing somebody and the flu numbers are there in your community and they are showing signs of either illness, err on the side of treating with Tamiflu if it's early, right? I mean, we know that Tamiflu doesn't really help after a certain after 48 hours or so of symptom onset. So if you're in the window, it's early, better to err on the side of treating with Tamiflu, even as you're waiting for your specimen, if you're not able to get a rapid response. Next slide. And so again, here's just some of the data around the clinical benefit of early Oseltamivir treatment. So adults, early Oseltamivir treatment significantly reduced illness duration, lower respiratory tract complications requiring antibiotics, and hospitalizations for any cause. So it has been shown to work. Again, this is when you give it early. So and I will say in terms of our staff that work at our clinics, if there's one thing we've learned about the pandemic, people should stay home if they're sick, and they should tell people right away when they're symptomatic. We all do it. We all kind of blow it off for a few days until we're in the bed and we feel like a truck's hit us. This is a time now to say, if you're starting to feel symptoms, err on the side of reporting that, not going to work, and calling your doctor. Next slide, please. All right, so just some guidance around giving flu vaccine during the pandemic. We have some great pages on our website that provide guidance around when, if there's situations to give flu vaccine or not give flu vaccine during COVID. And essentially we have two ways we want to look at this. One, we want to protect our staff and other patients in the clinic. So if there's a concern that someone has flu-like illness and it could be COVID-19, and they know they've been in contact with someone else who has COVID-19, and they are quarantining, that is not the time to come out and get your flu shot. So ideally, we're not having people come to get their flu shot while they're symptomatic for COVID. Now, in our population of patients, that may be a completely different situation. We might couple testing for COVID-19 with flu vaccination. Folks may be in shelters. So our standard kind of recommendations apply. And we are, not able to, there's not really good clinical reason in an outpatient setting to not give someone their flu vaccine unless they're quite febrile or they're starting to show moderate symptoms. So while we don't want to encourage people while they're in quarantine to come and seek a vaccine, if that's the only time you're going to give it to them and they don't have fever or moderate symptoms, then you're good to go and you should give your flu vaccine. Next slide. Sorry, Courtney. We'll get to Kathleen's comms materials because those are the most important. Again, just PPE during giving vaccine, we're trying to just make sure to keep those same standards, be extra careful with the folks that are going to be giving the vaccine. Next slide. In addition, on these websites, it outlines how to do a flu vaccination, either through a clinic building, how would you separate your areas to keep people spaced out and keep things as safe as possible. And then there's the next one for a drive-through, which may or may not take place. And I know as it gets colder in the north, you guys may not be able to do walkthroughs as much or out in a parking lot. But again, you can kind of see how you would do the flow to keep things as safe as possible. Next slide. All right, so I'm going to turn it over to Kathleen and hopefully we can run through some of these comms materials.
Thanks. Hi, Kathleen LaPorte. I work in the influenza division. I've been working closely with Sapna to share some important information on influenza vaccination. I am really just going to echo a lot of what's been shared. I think most of us are aware on how important flu vaccine is this year, and not only to protect individuals and ensure that they don't get sick, but also, as mentioned, to reduce our overall burden on the health system. So what I'm going to cover is very high level. We have a lot of different material and different channels that they can be shared on, but we know that you guys are the experts in reaching your population. So please feel free to reach out to me if there's any way we can help shape messages or shape materials so they're more applicable to your population. The most important thing is that we want to make sure the message is received. So please do feel free to reach out, and I will share with Courtney after this a huge list of all our materials and how to access them. But jumping in really quick, these first two slides are some examples of our flu vaccination campaign materials for this season. And we were able to do some message testing this summer on motivating messages when it comes to recommending a flu vaccine to individuals, specifically adults. And what we found is those messages that are motivating are explaining to people that a flu vaccine protects themselves, it can protect their family or loved ones, and it also can protect their community. And that's a general message that people gravitate towards year to year when it comes to vaccination. But particularly this season, in the context of COVID-19, we also tested some messages on flu vaccinations as a way to reduce the overall burden of respiratory illness and protect our health systems, preserve medical resources, protect our frontline workers. And we found that these messages really appealed to those who weren't sure if they were going to get a flu vaccine or didn't plan on getting a flu vaccine. So we think, sharing those messages that you're getting vaccinated not only to reduce your own risk, but also knowing that we have overwhelmed health systems, and anything we can do to reduce the number of people who have to go into a hospital will be critically important in this pandemic. Next slide. So in addition to our messaging on recommending flu vaccines, we have several materials that talk about our preventive actions for this fall and winter. And these really pair together our COVID-19 preventive messages and our flu preventive messages. And we know there's a lot of overlap there. And so the core of our messages here are mask up, lather up, sleeve up. Mask up, wear a mask when you're out in public, practice social distancing, lather up, wash your hands often, and sleeve up, roll your sleeve up for your annual flu vaccine. So we have a whole suite of materials here. This is a video we don't have to play now, but again, I'll share a lot of these resources, print resources, social media graphics, and others. Next slide. Oh, there we go. And then this is one of the communication activations that we're doing this season. Really, it's something we're sharing on social media, but it's an example of that kind of communication outreach that we're encouraging everyone to do and lead by example, whether it's leaders in your industry, leaders in your specific office or community, and really leading by example, showing their own influenza vaccination photos. We have these customizable frames where people can put their own photo in and share with others the importance of a flu vaccine. Next slide. And then this is just part of our laundry list of materials. As I mentioned, we have web materials, we have graphics that can be shared on different social media channels. We also have print materials, resources for consumers and healthcare providers. And we also have resources available with that mask up, lather up, sleeve up message available for print in 15 different languages. So I'll be sure to send all these links, but again, just echoing, as people are able to review these, please feel free to reach out if there's other messages or resources that would be helpful to you.
Thank you both so much. That's incredibly helpful. And as they both mentioned, we will be sending a lot of resources that we will link afterward and on our website. So thank you so much. And I know that's a lot of information in a short time, so we're hopefully going to just move through so we can get to some Q&A as well. And up next, I'm going to turn the floor over to Kevin Flowers from Mercy Care.
Hello, can you guys hear me? Great. Thank you for the opportunity to share what we're doing here in Atlanta with COVID and flu in the homeless population. So I just want to give you an overall view of what we're doing and some of the challenges we had. Okay. Our team here comprised of, as you can see, folks do the registration, 3 nurses, 1 nurse practitioner, 1 MD, 1 certified medical assistant, and myself that does the coordinating and reaching out to the partners and the overall operation of the events. Next. What we do here then is I'll reach out to the homeless partners through the continuum here in Atlanta. And some of those include, of course, the shelters, drug treatment centers, soup kitchens, and transitional housing. Anywhere they congregate, we try to make it our efforts, to make big efforts to be there for them. We schedule these things in advance, the events, and I send them out to the continuum in 3 months span. So everybody knows what's going on, at least for 90 days out, where we're going to be and what time. Next. Thank you. The day of the testing is, the flow is like this. I'll just, probably won't go directly by the slides, so just speak. In advance, I will go out prior to doing any of the events to look at the lay of the land. Every location is different and every location has their challenges. And so I go out in advance to try to weed that out and see what we're going to need to make it a smooth event. Our facilities department will pack our vehicles, our vans for us with, of course, our test kits, our PPE, tents, tables, coolers, all the supplies that we need. I asked my team to be there 1 hour in advance because we're the ones also doing the setup and the breakdown. Okay, next. So our day will start out with a huddle. We generally do a reflection or a prayer to get our day started. At that time, we will partner up. Who's going to be working with each other. We'll discuss the flow. As I said, each location has its challenges. I'll try to get an estimate of how many may be coming to that particular event through the partners. They know about how many people they may feed at this event or how many people may be living in that location. That kind of gives us an idea of what we're looking for that day. As individuals step up to be tested, the individuals are registered in a pre-formatted spreadsheet that's going to gather their demographics. At that time, too, we will also give them instructions on how to retrieve their results, answer any questions as well. The spreadsheet is created with unique numbers. These particular unique numbers will follow that individual. You know, if we test them second, third, fourth time, that same number will follow that individual. So we keep a running directory of all the people that we test. So once they present to the table to be tested, I have one individual that's registered in the computer and I have one sitting next to them that's doing the labeling. The person on the computer will enter everything. The person on the label will label it. The two of them will verify the information for accuracy. And once again, then have the patient look at the label and also make sure everything is accurate for them. Then they're given their specimen and head over to be tested. At that time, we will offer also flu shots for them once they get back there. We've just incorporated that because of the season that we're in now. So that has been going pretty well also. Those that are expecting to get flu shots or wanting one, we go ahead and provide them with the appropriate consents and BIS, educational information and whatnot. Next, please. Once the client reaches the testing center, yet again, the information is verified again. The doctor or the individual that's doing the testing will once again ask him, is this you? We want to make sure that specimen belongs to that patient because there are challenges in locating them sometimes. The procedures are explained to them and give them an opportunity to ask any questions about COVID or educate them on the COVID and flu at that time also. The specimen is collected and of course packed away as prescribed in a cooler on the proper temperatures and whatnot. Before the individual walks away, we always check with them to make sure that they're okay. Some people have lots of fear about things going up their nose, and we just want to make sure that they're okay and if they may not have a nosebleed or anything as well. I'm partnered with a lab here in Atlanta that runs the test for us, and generally the test will come back 2 to 3 days. We instruct the patients, we give them contact information and phone numbers on how to get their results. Next. Here again, 2 to 3 days is about the turnaround. Lately, I've actually been getting them next day, which has been phenomenal. There were challenges early on when a lot of folks were testing. The laboratories were overwhelmed, and there were times when it may have been a week, So thankful for that opportunity working with this laboratory that gets it to me pretty much the next day. For the individuals that we're seeing out there that are homeless, some of them are actually Mercy Care patients. So for those that are actually Mercy Care patients, we will also document these tests, the flu shot and the COVID in their records here at Mercy Care. Next. Some of our biggest challenges out in the field has been language barriers. There was at one point I didn't have someone that speaks Spanish with me, but I am fortunate now to have Dr. Mercado with me, and she speaks Spanish and to help us reach that particular population. We have had clients come up that were deaf, and that tended to have been a struggle because we didn't have anyone to sign with them and to be able to communicate with them. But we managed to go ahead and service them the best we can. And people with different disabilities, mental health, particularly with the homeless population that we're testing, have some difficulties there with fear and trust and just a gamut of things that we have to get them comfortable for taking the exam. Wheelchairs. Never thought that would be a problem really, but it does present a problem. I went to one location and there were like 6 people that were in wheelchairs. Like, wow, and how are we gonna really take care of them and get them moving them around? But we managed to do that also, but we wasn't quite prepared for getting folks up ramps and down ramps and that kind of stuff, So I'll check with the service provider that I'm working with, and they generally can tell me, oh, well, I have 80 people coming to eat today. I may have 60, I may have 300, I may have 200, whatever. That gives us an idea of how long we may need to stay there. Typically, it's about a 4-hour block of time that we give them. That particular time is determined by the service that provider is giving. They may be just offering breakfast and we'll go for that particular time. Or they're offering dinner, or we'll go at that particular time in the late evening. So we make it as convenient to capture as many as we can. Many actually are okay with getting the flu, but don't want the COVID. So, and you think, hey, up your nose or a needle, and they're okay with the needle. So we do offer that. We're not forcing anyone to be tested. So we still take care of them and offer that flu shot. Then that's also recorded in our state immunization database. Some other huge challenges have been weather, because we're outside predominantly testing folks. And I've had some tents lifted by the wind before, and we just wasn't ready for that either. But we've learned through these experiences how to tie them down well and be prepared for rain or cold weather or whatnot. But there were some challenges there with that in the beginning. Okay, is that it? One more?
That's it.
I think somebody else is up now, but I'm open to any questions at the appropriate time, and just kind of, there may be some other things that you may be interested in what we did and how we're doing here. We've tested over nearly 6,000 just in the last months here. With that, only about 2% actually have been positive. So we were thinking that those numbers will be much higher because of the population that we're dealing with, but it hasn't been, which has been fortunate. Other partners also came in early on to help the homeless in Metro Atlanta. Those that ride the train, hanging out in the parks or just out. They were offered the opportunity to be housed during this time, during this pandemic. And so that gave an opportunity for them also to get an array of services that they probably wouldn't have gotten otherwise. When the results come back, if someone is positive, the flow, then we will reach out to the individual. The contact information, the county takes care of and find out, do the contact tracing. We'll do the placing of the individual for quarantine as appropriate. And for those that are not needing it, we'll just continue to test them as they come. One other challenge has been locating if they don't have a phone number or if they're unsheltered. So at that time, if someone presents, say, I don't have a phone number and I'm not housed. So then I try to just find out, okay, what park do you sleep at, or where could I find you if I had to? So that we just dig a little deeper so we can locate them if we had to.
Thanks so much, Kevin. This has been incredibly helpful. And the level of detail, I mean, I can't believe the amount of people that you have tested and your ability to provide this service all across the city. So this is really incredible work. So thank you so much for sharing. And we'll have people put questions in the Q&A. And now we will turn it over to Dr. Crosland from Community Healthcare. Take it away, Catherine.
Thank you so much. Can you all hear me? Okay. Thank you so much, Courtney. This has just been a great a great wealth of information. So I really appreciate it, and I'll take some things away to our practice. So my name is Catherine Crosland, and I'm a physician with Unity Healthcare, which is the largest federally qualified health center in Washington, D.C. We also have a healthcare for the homeless program, which is the primary provider of medical care for people experiencing homelessness. I've worked there for 11 years and have had the privilege of directing the homeless outreach program. Just like Mercy, we are in shelter-based clinics, we're in day centers, we have a street medicine program, and we have been, even pre-COVID, we have been a partner with the DC's Department of Health, as well as the Department of Human Services, in trying to provide coordinated citywide responses and care for people experiencing homelessness, including partnerships around flu vaccines. Every year up until now, we've had flu vaccine campaigns at shelters, at day centers. We've even done them in the park, outside. So this is kind of part of our fabric and what we do every year. And so I just wanted to take a minute to talk about what things look like and how they look a little different this year with the COVID pandemic. So given our role serving people experiencing homelessness in DC, Unity Healthcare was a natural partner for the Department of Human Services and DC Health when trying to respond to the crisis, the pandemic of COVID-19, as it would affect this most vulnerable population, people experiencing homelessness. So as many places in the country were doing, we created isolation and quarantine sites. We refer to them as ISAC, and these are hotel shelters, basically, that allow for people experiencing homelessness to come in if they have any number of the following conditions. So either they've been diagnosed with COVID-19 and they need a place to isolate, they have symptoms that are concerning for COVID-19, and they can come to the hotel to get tested or to await their test results, and to quarantine or isolate. And then finally, for people who are close contacts of somebody who's been diagnosed with COVID-19. So sometimes in the shelter, if somebody tests positive for COVID-19, we'll get not only that person coming to the hotel, but then 9 or 10 people close by in bunk beds near that person as close contacts. The primary goal of the program is to identify and isolate or quarantine as quickly as possible people who are living in large congregate shelters, so that we can decrease the risk of spread to the rest of the community. And then at these sites, Unity Healthcare provides medical care, just routine medical care for folks who are here for their isolation or quarantine period. We also, as I mentioned, have a strike team. The Department of Human Services has created a strike team that comes out and that provides COVID testing for those people who need it, as well as we're now offering flu vaccines. We also have behavioral health staff on site. Next slide, please. And in addition to the isolation and quarantine sites, the Department of Human Services and the city took an additional step to create hotel-based shelters for those people thought to be most at risk for developing severe complications from or death due to COVID. And so these hotels, which we stood up in late March, really are there to reduce exposure in the first place to this most vulnerable population. We are currently able to offer a rapid COVID test for every single person on admission to the site. Because of the fact that it's a highly vulnerable population, we want to make every effort to make sure that nobody at these sites has COVID, and if somebody develops symptoms, then they go to the isolation and quarantine site to make sure that there's no risk of spread to this vulnerable population. We have clinics. Unity Healthcare has clinics on site at all of these locations, and again, we're doing the flu vaccine. Next slide. So this is just, I'll breeze through these. This is just a sense to show you how the PEPV sites have progressed over time. In March, when we had just one hotel, we were very kind of strict in our criteria to make it available just to the most vulnerable. And as time has gone on, we've relaxed the criteria to make it available to more people. We have opened more hotels. We now have 3 hotels, and we're moving towards double occupancy with a goal of making these services available to about 700 individuals. Next slide, please. And this is just a little bit of information just to show you kind of who we're treating, the demographics. It says here, you can see that the majority by far of people that we are serving identify as Black or African American. And I think that, you know, while we in this field of providing medical care to people experiencing homelessness, we have, I think the sort of the good news is that it really shines a light on how housing is healthcare and how homelessness is a public health crisis. And as we have seen with COVID, it really has brought to light really systemic disparities in health, especially as COVID has disproportionately affected our Black and Brown neighbors. So that's just a little bit of a sense. I think that because of the people who didn't report, that the number of Black and African American is actually even higher than that suggests. Can you just back up for one quick second? Sorry. And then, you know, by age, this just shows that obviously the older somebody is, the more at risk they are, and then overwhelmingly we're treating males. Next slide. And then this is just a little bit of the sort of the medical conditions that we're treating, just to give you a sense of the vulnerability. You can see 10% of the patients that we're treating have HIV, end-stage renal disease, even though it's a small number. People, just imagining anybody living on the street or living in a shelter who's going to dialysis 3 times a week, to me is just unfathomable. So that's just, we have a number of patients with active cancer who are undergoing chemotherapy. So we're really protecting a very vulnerable population. Next slide. And this just shows that we've added 3 hotels. And this is part of the winter plan to provide a safe place for as many people as possible going into the winter, where we're expecting a potential spike in COVID cases as well as flu cases. And the hope, next slide, by expanding the PEP-V services, our hope is to de-densify the shelters. The low barrier shelters will be operating 24/7 at what we call COVID capacity, which is about 60% of usual capacity. My fear is that that's not even enough to provide really proper social distancing, but it's certainly an improvement over what it was before. In addition, we'll have recreation centers that usually, there are seasonal hypothermia shelters, which are usually only open when a hypothermia alert is called when the temperature drops below a certain amount. But this year, our hypothermia shelters will be open 24/7, again, to provide that extra ability for people to come inside, because as we know, people who are outside don't have those day centers and the libraries and all the places that they rely on to go inside and warm up. So Unity's role through all of this, as I've said, is to provide medical care. We continue to provide medical care in the low barrier shelters where we have clinics. Unfortunately, some of that has been scaled back in order to focus attention on these new alternate care sites. But we do continue to see folks in the low barrier shelters. We see folks in some of the day centers that are slowly opening back up in limited capacity with scheduled appointments inside. Unfortunately, people aren't coming inside and sitting all day and having lunch and sort of having a place to stay warm, but they are being allowed in kind of schedule by schedule. And then we also are still doing our street outreach, which is, again, it's a little bit more limited than previously, but we are trying to maintain our presence to care for folks. And in all of those settings, we are doing flu vaccine campaigns. So we have been very aggressive this year about proactively reaching out to the shelters, setting times, just like Mercy was showing the sort of the really detail-oriented way in which you've got to kind of plan for everything. So we're doing that with our flu vaccine clinics. I should mention that Unity Healthcare has COVID testing tents all across the city. And so those are not just for people experiencing homelessness, but certainly available to people experiencing homelessness. For people experiencing homelessness, we are offering COVID testing, like I said, at the PEP-V sites, these high-risk sites. We have done several rounds of site-wide testing, again, to make sure that the population is safe and that we don't have folks who are there inadvertently who've tested positive, potentially exposing other folks. At the isolation and quarantine sites, we are definitely testing everybody who comes in, whether they're there for close contact or with symptoms. And then as far as the flu vaccine, we have offered the flu vaccine campaigns at both of these alternate care sites. So the PEP-V sites, we have offered every single person in those sites the vaccine. We literally just went door to door and vaccinated people in their rooms or right kind of in their doorway. And at the isolation and quarantine sites, because there's a sort of a revolving door of people staying there for 2 weeks or 10 days, depending on their symptoms and how long they need to isolate, we have a standing flu vaccine clinic every single Wednesday. And so whenever somebody gets admitted to the isolation and quarantine site, and I'm actually here in the hotel right now, we offer to have them get a flu vaccine the following Wednesday. And anybody who wants that we'll just put them on the schedule because of the importance of getting that tested. So one thing that we are still working on is, and I was really happy to hear about the information about like who to give flu vaccines to and who not to. We have been following that. We do not give the flu vaccine if somebody has a fever or is really feeling poorly. But if somebody is there for quarantine or if they have COVID, but they're doing pretty well, we offer all of those folks the flu vaccine. For the rapid flu, we're trying to figure out the best use for that. So as one of, I think Sapna from CDC was saying, only use it in the clinically meaningful settings. And so we have decided that we will have most of our our rapid flu tests at the isolation and quarantine sites, because as we all know, if you have symptoms that could be the flu, it could also be COVID. And so we aren't going to swab somebody at one of our shelter-based clinics and say, oh, well, it's the flu, and so you can just stay put, because they potentially could have COVID as well. And so anybody with symptoms will likely this winter be referred to the isolation and quarantine sites. And once they are here, our plan was to provide the rapid flu to anybody who has developed symptoms within the past 48 hours, with the understanding that if we catch somebody within that window, we can offer them Tamiflu. If we catch them outside that window, it might not make sense to test them, except for maybe our own sort of information, but we will definitely test everybody for COVID who comes to the isolation and quarantine sites. One thing I will also say, and then I'll wrap up because I know that we're pressed for time, is that while we have been growing our PEP-V program, the protective hotels, the isolation and quarantine sites, we had at our peak 4 hotels with a maximum capacity of about 450 beds. And we were close to 400 people at our peak. And again, it's a revolving door. We would have as many as 66 admissions in a day across the site. But we are now down to 1 isolation and quarantine hotel, and it's not even half full. We're about a quarter full. And so we anticipate with the coming winter and people developing symptoms that could be concerning for COVID, that we will have to sort of ramp up the number of hotels that we have if we get a number of people coming in with flu-like symptoms that could be COVID, and we have to sort of test and quarantine for both. So I think that's where I will end and turn it back to Courtney.
Thanks so much, Catherine. Really appreciate that. And I just continue to be absolutely amazed at the mobilization of resources and the interconnectedness and interagency partnership that you're demonstrating in DC. It's really incredible. Thank you so much for that. I'll ask you one quick question that I saw in the Q&A to kick us off. We'll do a rapid fire. One of the questions was, how are you transporting folks between these sites, to the sites and from one site to another?
That's a great question. We have a very intricate van transportation system that we've come up with. I should say that the Homeland Security Emergency Management Association Human Services Branch, the mouthful, has really been providing a lot of assistance for us, and the van transportation is part of that. And so anytime somebody has symptoms, whether you're at a shelter or a clinic, or a CAPT site or a hospital, they can call a hotline number and just say, I have somebody here with symptoms. I need them to be transported to one of the isolation and quarantine hotels. And then we will send a van and pick that person up and bring them to the isolation and quarantine site.
Thank you, that's helpful. Sapna, if you're still on the call, I was going to ask if you could answer a couple of questions here, rapid fire style, around what is the percentage of homeless population that is testing positive for COVID right now? And then similarly, what are thoughts you have about triaging isolation and quarantine while folks have multiple URI type illnesses?
Okay. So the first question is, how many homeless people experiencing homelessness are testing positive for COVID?
Mm-hmm.
It's a very, very hard question to answer. We do have, I mean, Courtney can talk more, or Barbara DiPietro, she's on, can talk more about the dashboard that we've put together, but it's all reliant on people uploading and sharing their data. So nationally speaking now, I do get an email kind of every morning that gives us a little bit of a picture, but I'm going to actually defer to Barbara and see if she has any updates in terms of what we know. I will say that in the beginning, it was so varied based on the type of outbreak your community was having. So while we saw numbers in Boston and San Francisco that were in the 40 to 50% percent of people within a given facility, for example, testing positive, many of them asymptomatic. Other places that maybe were having slower growing epidemics, had 5% or less. So it just really varied. And so we are trying to track that, but I don't know that I have a great answer. So the second question, Courtney, was?
Just some guidance around isolating when folks have URI symptoms that are, unclear if it's COVID, flu, or any other URI.
Yeah. So I think in general, the constellation of fever along with respiratory symptoms have been the triggering for isolation. So if someone has congestion, headache, independent of fever, I don't know that it's feasible to think that we're going to isolate all of those people. And so I think, fever is really predictive, or more predictive, or more correlated, I should say, than other things. The loss of smell and taste, although it's not, less than half of people have that symptom. When you have it, that's seeming to be quite specific. Catherine, do you want to speak to that at all, or?
So yes, we have had about just over 300 people in the homeless continuum of care test positive, and we're at about, and I should say, I'm so sorry, all of this is directed at individuals experiencing homelessness. So the homeless families is sort of a different thing. People have much more kind of privacy and sort of almost little like their own apartments in the family system. So I'm not speaking to that, but in the single adult population, we have about 3,000 people between the shelters and unsheltered individuals, and we've had about 317, probably more than that now, cases, and and just over 17 deaths that I'm aware of. And I think that there may have been another one or two. But so that's about 10% for us. So it's not far off the 8.18%, but
thanks, Catherine. Well, we are at,
and we can try to get more data on that.
Thanks so much. We are at the top of the hour. I'd like to thank our speakers so very much for their time and effort. Catherine, Kevin, Kathleen, and Sapna, thank you for sharing your expertise. Thanks for all the amazing work you're doing for your communities. I just want to also promote, please, as you're doing testing and flu vaccinations, please enter them into our dashboard on our website. Barbara put the link in there again. And come join us again next week as we discuss cold weather and disasters, same time, same place. And then finally, Friday, November 20th, we'll discuss evictions and social upheaval. So please come back so we can continue the conversation, and feel free to send me any emails if you have any additional questions, and we'll be posting with a lot more of the information and links that we had mentioned throughout the conversation. So thanks so much for everyone for joining us. We really appreciate your time and hope you all take care and have a wonderful weekend. Bye.